Welcome back to the deep dive. Today we are tackling a really heavy topic. I mean, if you're in aesthetic surgery, this is the bread and butter.
Oh, absolutely. This is the stuff that can keep you up at night.
We are getting into the weeds of mastopexy and, of course, the big one, the augmentation mastopexy.
It's the procedure everyone wants, and it's arguably one of the hardest to get perfect. Every single time.
The numbers really back that up. There's data showing this massive shift.
Huge shift.
Between 1997 and 2008, mastopexy volume went up almost 400%.
394% to be exact.
Yeah, and that's not a trend. That is a complete changing of the guard in what patients are asking for.
It makes sense, though. Massive weight loss is more common. People are living longer, more active lifestyles. But for us, as surgeons, it presents a very specific headache.
It's totally different from a reduction, isn't it?
Completely.
And I think that's where we should start, because a reduction, it feels safe conceptually. You have too much tissue, you cut some out, you shape what's left. But a pexy.
A pexy is a deficit problem. You're dealing with a relative deficiency of parenchyma inside a skin envelope that's just way too big.
It's like a pillowcase that's 2 sizes too big for the pillow.
Exactly. And you can't just cut away the pillowcase without thinking about the actual shape of the pillow inside. You're fighting gravity, you're fighting pore elasticity, maybe some post-pregnancy atrophy.
So your mission is to lift and reshape that tissue, but without actually reducing the volume. You're trying to maximize it, really.
That's the game. So for this deep dive, we want to walk through that whole decision tree.
Right. How do we maximize the ptosis correction, keep the scars as minimal as possible, because patients negotiate for every millimeter.
They do.
And most importantly, prevent that bottoming out 6 months down the line.
That's it. Balancing the biological reality against that aesthetic desire.
So let's start with the absolute basics of assessment. Regnault classification. I know every resident learns it in week 1, but it dictates the entire algorithm.
It's the common language. It really is. If you misclassify the dreaded ptosis, your surgical plan is... well, it's doomed before you even make a mark.
So let's run through it. First degree or minor ptosis?
Nipple is right at the level of the inframammary fold. Simple.
Okay. And second degree?
Moderate. Now, the nipple's fallen below the fold, but, and this is key, it's still sitting above the lower contour of the breast. It hasn't totally bottomed out yet.
Got it. And third degree is severe?
Right. The nipple is at the very bottom of the breast contour, usually pointing straight at the floor. That's the obvious one. But the ones that really trip people up are the variants.
Glandular ptosis and pseudoptosis.
Exactly.
I wanted to drill down on those because they sound similar on paper, but the surgical approach is night and day.
Oh, completely different. So glandular ptosis is when the nipple is actually in pretty good position. It's above the fold.
Okay.
But the parenchyma, the actual breast tissue, is sagged, and it's hanging below the fold. So it looks droopy. But the nipple areolar complex is where it should be.
So just lifting the nipple fixes absolutely nothing.
Correct. You have to lift the gland itself. Now, contrast that with pseudoptosis. This is what you see in a hypoplastic or a very small breast, that deflated look after pregnancy.
The empty sock.
The empty sock. The nipple is high, but the tissue has just slid down off the chest wall.
There was this concept in the notes from Brink that I thought was a really fantastic way to visualize this whole thing. He describes it not just as sagging, but as a pirouette.
I love that concept. It totally changes how you see the breast in 3 dimensions. Brink says the cleptotic breast basically pirouettes around its base. It's not just a vertical drop like an elevator going down.
The nipple actually rotates inferiorly.
Precisely. So you get this elongation of the geometry. The distance from the clavicle to the nipple gets longer, and the distance from the clavicle to the IMF gets longer. It's a dynamic rotation.
And if you don't unpirouette it, you haven't really fixed the problem.
You haven't fixed the problem.
So you're in clinic, you've classified the ptosis, now you have to triage. It feels like the critical decision point is balancing 3 things: volume, lift, and scar.
That is the eternal trade-off. It's a triangle, and you can usually only pick 2.
Right.
If a patient is willing to accept an implant, well, you can often get away with a shorter scar because that volume fills out the loose skin envelope.
But the implant alone won't fix the nipple position if it's really low, will it? You can't just stuff the envelope until the nipple rises.
No, and that is a classic rookie mistake. You cannot push a nipple up with an implant alone if it's truly ptotic. You just end up with a big, low breast.
Which brings us right to the surgical algorithm. Stephen's approach is really useful here because it breaks it all down by grade and by what the patient actually wants.
It's a great roadmap.
Let's walk through it. Start with pseudoptosis, the empty sock.
Okay, so if they want to be larger, it's an easy day.
Yeah.
Biplanar augmentation, The superior fullness from the implant balances everything out. The implant does the lifting for you.
And if they like their size.
That's a tougher spot. If they want to stay the same size, but look, perkier, you have to do a small resection with a biplanar aug, basically swapping tissue for silicone.
Or just a straight pexy.
Or a straight pexy. And if they want to be smaller, then you're looking at an inframammary wedge excision. You're just taking out that bottom crescent of tissue to tighten everything up.
Okay, let's move on to true Ptosis, grade 1. The nipple is down, but we're talking less than 2 centimeters of lift needed.
This is prime territory for the circumareolar techniques, the donut lift. If they want to be larger, you do an aug plus a circumareolar pexy. If they're happy with their size, just the pexy.
That 2 centimeter mark, though, seems to be a hard line. What happens when we get to grade 2? Now we're talking 3 to 4 centimeters of lift.
This is the transition zone. This is where the donut starts to fail. If you try to lift 4 centimeters with just a donut, you're going to get a flattened, wide areola.
The dinner plate.
The dinner plate. So for grade 2, if they want to be larger, Stevens prefers an augmentation mastopexy, usually with a circumvertical approach.
And if they don't want an implant?
Then you're looking at a vertical pattern, or a wise pattern, the anchor scar. You just need more skin excision than a circle can give you.
The notes had some very specific numbers for the vertical wedge excision. These nipple to fold distances? Why so granular?
Because that's where you're setting the final shape. They're benchmarks. If you're aiming for a B cup, you want that vertical limb to set the nipple to fold distance at about 7 to 8 centimeters.
And for a C cup?
You need a bit more drape, so 9 to 10 centimeters. For a D cup, 10 to 11.
What happens if you ignore that? Say you build a D cup, but set the distance at 7 centimeters.
You'll bottom out almost immediately. The nipple will be looking at the sky, sitting way too high, and the lower pole will just bulge out. You have to respect the geometry you're building.
Okay, finally, grade 3. More than 4 centimeters of lift. This is significant.
At this point, you have to stop negotiating with the skin. You usually have to commit to the anchor, the wise pattern.
There's just too much skin.
The skin envelope is just too redundant for anything less. If they want an implant, it's a wise pattern augpex. If they want to be smaller or stay the same, it's a wise pattern pexy.
So you run out of ways to hide the scar?
You do. But a well-healed anchor scar on a shapely lifted breast is always, always better than a short scar on a breast that looks like a box.
That's a great segue into the techniques. Because the skin-only mastopexy, it gets a lot of hate. Is that deserved?
It fails. That's the honest truth. Skin is elastic. It stretches. It's not a suspensory ligament. If all you do is tighten the skin wrapper, gravity will win within a year.
So what's the fix? How do you get longevity?
You have to reshape the parenchyma, the inside. You have to suture the gland, use fascial suspension, transpose flaps. You have to build an actual structure that the skin just drapes over.
The skin shouldn't be holding the weight.
It should never be holding the weight.
Let's break down these techniques, starting with the circumareolar one for grade 1. There's Spear's rule, which is supposed to prevent that widened, flat areola.
Ah, yes, the dinner plate areola. We've all seen pictures. To avoid it, Spear says the ratio of your outer circle marking to your inner circle should be no more than 2 to 1.
Any wiggle room there?
Absolute maximum 3 to 1. If you try to cinch down more skin than that, like a drawstring bag, the tension is just too high. The scar stretches, the areola flattens. It looks terrible.
To help with that tension, Benelli came up with the round block. How does that work?
It's basically a permanent purse string. He uses a non-absorbable suture, a cerclage, around the areola to mechanically hold that diameter so it can't stretch out over time.
Smart.
He also describes plicating the glandular base to create projection. So again, the skin isn't doing the heavy lifting.
And then Ghost took that a step further with mesh.
Right, the double skin technique. He uses a mixed absorbable and non-absorbable mesh, almost like an internal bra, sandwiched between the gland and the skin. It's a really interesting concept for long-term support.
Okay, let's move to the vertical techniques. The notes call this the VOQ. I'm assuming that describes the scar shape.
Exactly. You've got the periolar O, the vertical V, and when you close it, it looks like a Q.
4 big names here: Lassus, Lejour, Hall-Finley, and Hammond. They all manage the blood supply at the pedicle differently. Let's start with Lassus.
Lassus is the classic, superior pedicle. He dissects the gland perpendicular to the chest wall. The key move is he takes the inferior glandular flap, folds it under, and anchors it to the pectoralis fascia.
Like folding a towel to get more height.
That's a perfect analogy. It gives great projection, but it leads to that Concord nose appearance right after surgery.
It's Concord nose.
Yeah, the breast looks pointy and high. Patients can freak out. But, You have to tell them to trust the process. It settles into a beautiful natural shape in about 2 to 3 months.
Then there's Lejour. How is her technique different?
Lejour is also a superior pedicle, but she relies heavily on lipo for shaping. And she does this really extensive inferior skin undermining. She gathers, or pleats, the skin on the vertical scar. It looks really bunched up on the table.
A little scary if you haven't seen it before.
Very scary. Now, Hall-Findlay. This is a favorite for a lot of surgeons.
Why is that?
She prefers a medial pedicle. The big advantage is she doesn't undermine the pedicle at all, which preserves blood supply and sensation much better.
And she does something called auto-augmentation.
Right. She rotates medial glandular flaps up to fill the upper pole. You're using the patient's own tissue. It's fantastic for getting that upper pole fullness without an implant. You're borrowing from the bottom to fill the top.
Very elegant. Lastly, Hammond, the spare technique.
Short scar, periolar inferior pedicle. He uses an 8-centimeter inferior pedicle. The really cool thing he does is plicate the superior flap down to the pec fascia. It's a very controlled way to set that upper pole shape.
Okay, and the last category, the workhorse. The inverted T, or Y's pattern.
The trade-off is clear here. Predictable results versus a longer scar. But sometimes you just need the exposure. A good way to visualize it is the owl.
The owl.
Yeah, picture it. The periolar marking is the head, the vertical limbs are the body, and that horizontal wedge excision at the bottom. Those are the feet.
That actually makes it so much easier to remember when you're drawing it. Okay, let's pivot to the combination procedure. Mastopexy-augmentation. This is where the debate really seems to be. 1 stage or 2.
The old surgeon beware crowd says to stage it. Do the pexy, let it heal, come back 6 months later, and put the implant in.
And why? What's the fear?
Safety. When you combine them, you're disrupting blood supply, while at the same time putting the tissue under tension from an implant. The risk of necrosis, of tissue death, goes up a lot.
But experienced surgeons are doing this in 1 stage all the time.
They are. But patient selection is absolutely everything. If they're a smoker, diabetic, massive weight loss patient with poor tissue quality, you stage it. You do not risk the nipple. It is just not worth it.
For a 1-stage procedure, you have to make some technical adjustments, right? You can't just do a standard AUG and a standard pexy and hope they fit together.
No, you have to mark conservatively. The minute you put that implant in, the skin envelope stretches. The nipple position will rise just from the volume pushing it out.
So if you mark too high to begin with,
The nipple ends up on their neck.
and the pocket for the implant.
Submuscular is generally recommended. It preserves the perforators to the breast tissue because the implant is behind the muscle. It also lowers your contracture risk.
And there's a key pearl here about incisions.
Yes, this is so important. Try to orient your parenchymal incision, the cut into the gland, to place the implant in a different direction than your skin incision.
To diffuse the tension.
Exactly. You don't want a direct line from the implant to the outside air. If the wound gaps, you want tissue underneath, not a visible implant.
What's the usual sequence in the OR? Pexy first.
Typically, yes. Although some surgeons will place implant sizers first to stretch the skin and see where everything lands before they commit to the skin excision.
It's like try before you buy for skin excision.
It is. It takes a lot of the guesswork out of it.
We have to talk about when things go wrong. Complications. There's a specific deformity you see with this combo procedure, the Snoopy deformity.
The waterfall effect. It's a classic complication. It's hard to look at.
Describe what that looks like.
So picture Snoopy's nose.
Mm-hmm.
The implant stays high on the chest wall. Maybe it's encapsulated. But the patient's own breast tissue slides right off the front of it and just hangs down.
So the implant is up, but the breast is down.
Exactly.
Mm.
The nipple ends up pointing toward the floor. It looks totally disjointed, like 2 separate mounds.
Yeah, fix.
You have to go back in. You need to do another mastopexy to lift that tissue back over the implant. And often, you're exchanging the implant or adjusting the pocket to get them to marry up again.
And then there's bottoming out.
That's when the implant itself slides too low. Or, more commonly, the inframammary fold gets lowered because the surgeon dissected too far down.
Is that a hardware or a software failure?
Usually surgical error.
Hmm.
Over-dissection of the fold. The fix might be a capsular trephy, suturing the pocket, or even using ADM and a cellular dermal matrix to create a sling to hold the implant up.
What do the numbers say on revisions? How often are patients coming back?
A review of 150 cases showed the #1 reason for revision was poor scarring, about 6%.
So it's the visual evidence of the surgery.
Yes, which goes right back to our first point. If you try to force a short scar on a grade 3 ptosis, you're going to get a bad result and a bad scar.
Interestingly, The notes point out that in combined procedures, implant-related issues are actually more common than tissue-related ones.
Yes. As a surgeon, your biggest fear is necrosis, tissue dying. That's what keeps you up. But statistically, you're more likely to deal with capsular contracture or the patient feeling the implant edge or just wanting a different size down the road.
Speaking of necrosis, reoperating on a breast that's already had a pexy that carries higher risks.
Much higher risks. The tissue is thinner, it's atrophic, and critically, if they've had a prior pexy, you must know the original pedicle orientation.
Why is that so critical?
Because if the first surgeon used a superior pedicle and you come in and cut across that to make, say, a medial pedicle, you've just devascularized the nipple.
You've cut off the blood supply.
You cut it off, and you'll lose the nipple, so you don't have the op note from the first surgery.
Be extremely cautious.
Assume the blood supply is compromised. Use a central mount technique or something that preserves generalized flow.
We've covered so much ground here, from Regnault grades all the way to the whole Finlay flap. What's the overarching philosophy someone should take away from all this?
The core tension in mastopexy is always the scar. Patients want no scar, but they want a perfect, lifted shape. The takeaway is that the shortest scar is not always the best scar.
Don't chase the short scar if it kills the shape.
Exactly. If you compromise the shape just to save 2 centimeters of incision, you'll end up with a boxy, flat breast that bottoms out in a year. You have to match the technique strictly to the degree of ptosis.
And focus on the parenchyma, not just the skin.
Manipulate the gland. Reshape the contents. The skin is just the wrapper. If the wrapper is holding all the weight, the wrapper will stretch. It's that simple.
That does it for this deep dive. If you're scrubbing in on one of these tomorrow, check your markings, check your ratios, and please watch that pedicle.
And maybe take a second look at that owl pattern. It really helps.
Thanks for listening. We'll catch you on the next one.